Hello. In this video, I'll be doing a deep dive on the core cardiovascular exam with a demonstration of specific maneuvers, as well as a discussion of common pathologic findings and how to document those findings in the medical record. Consistent with this physical exam series, the core exam includes both screening maneuvers to detect asymptomatic disease, as well as general diagnostic maneuvers with an emphasis on those that are supported by evidence in the primary literature. Along with the neuro exam, the cardiovascular exam is particularly nuanced and provides a rich window to logically connect observed findings with the underlying pathophysiology. Radhika here will be helping out today with our demonstration, but to start us off, I'll spend a minute reviewing cardiovascular anatomy as it relates to surface landmarks. So here's the torso. Let's visualize where the rib cage lies and the heart and great vessels beneath it. When describing the location of findings in the cardiac exam, we need to refer to the surface landmarks because that will be a point of consistency between exams performed at different times or by different people. Most of these landmarks are relatively obvious. For example, the ribs, the intercostal spaces between the ribs, the sternum, and the clavicles. The sternum is subdivided into three sections: the upper manubrium, the body, and the much smaller xiphoid process. The single most important landmark for the cardiovascular exam is the sternal angle, which is the near motionless joint between the manubrium and the body of the sternum, which is a subtle but palpable landmark in most individuals. The sternal angle is also occasionally known by the eponym angle of Louis or even angle of Lewis. Now, you might assume that angle of Lewis is a result of Americans just butchering French names, but in reality, the source of the eponym is not completely certain. So we really don't know how to pronounce it properly, which is just another reason to call this the sternal angle. There are two major reasons why the sternal angle is so important. First, it's the location of the junction of the second rib with the sternum, which then allows you to identify the number of every other rib by just walking your fingers down the chest wall. The second reason is because there are several critical anatomic structures beneath this landmark, most notably the aortic arch, the tracheal bifurcation, and the pulmonary trunk. There are also several imaginary lines on the chest wall: the midsternal, the midclavicular, anterior axillary, and mid-axillary lines. Together, the imaginary anatomic lines and the very real ribs and intercostal spaces create a grid that's used for localization. So for example, I could say that I heard a particular extra heart sound best in the left midclavicular line in the fifth intercostal space, which also happens to be a typical location of the cardiac apex in healthy individuals. There are also paired lateral sternal and parasternal lines, but these terms are rarely used in clinical practice. Unlike the pulmonary and abdominal exams, which are typically performed in one position each, the core cardiovascular exam is usually performed with a patient in multiple positions. We'll begin with the patient seated upright and fully covered. One might reasonably consider assessment of the pulse rate and blood pressure as a part of the cardiovascular exam, though in most clinical scenarios, these will have already been measured by a nurse or medical assistant. In this series, I cover the assessment of the vital signs in a separate video. From here, I think it's best to start with assessment of the patient's pulse. There are different opinions on which pulses to check in which patients. For an exam in a younger, healthy, asymptomatic patient, I would check just one radial pulse only, assuming the rest of the exam was also unremarkable. But even that might be reasonably skipped. Whereas in a middle-aged or older patient, or in a younger patient with significant cardiovascular risk factors, I would also check both the posterior tibial and dorsalis pedis pulses, given the possibility of picking up peripheral vascular disease. But because it's more efficient to talk about all the pulses at once, I'll demonstrate the location and palpation of each one now. Here's the location of the radial artery on the flexor surface of the lateral wrist. It's recommended to use your second and third fingers rather than your thumb to prevent you from mistaking your own relatively prominent thumb pulse for the patient's pulse. The brachial pulse is most easily felt by finding the biceps tendon in the antecubital fossa and palpating about 2 centimeters medial and 2 centimeters proximal. It requires more pressure from your fingers to feel this than the radial pulse did. Moving to the leg, the dorsalis pedis pulse can most often be felt in the midfoot, just lateral to the extensor tendon of the great toe, but there is some variability here, and you may need to feel around for it. For hospitalized patients with vascular issues, you sometimes see a little X drawn in pen on top of each foot, denoting where this pulse has been previously found to make serial examinations easier. Moving to the rear of the foot, the posterior tibial pulse is just behind and slightly below the medial malleolus of the ankle. It's not uncommon for a healthy patient to have either a non-palpable dorsalis pedis pulse or a non-palpable posterior tibial pulse, but it's rare for a healthy patient to have neither of these. Palpation of the popliteal pulse can be done in the sitting position, though it's easier when the patient is supine. Have the patient flex their knee to make an angle of around 150 degrees or so, reach around under the knee, and place both sets of your second and third fingers together right in the middle of the popliteal fossa. Then have the patient fully relax their leg in that flexed position. I like using the phrase, "let your leg sink down into my hands." Palpation of the femoral pulse is not often indicated, but is performed in the supine patient by placing your fingers just distal to the inguinal ligament midway between the anterior superior iliac spine and the pubic symphysis. Because of its location, you want to be particularly clear with telling your patient what you are about to do. While it's generally frowned upon to examine part of the body that's not been visibly exposed, this is a time in which I personally think it's actually okay. Last is the carotid arteries. These can be examined either with the patient sitting, supine, or anywhere in between. Palpate the carotids just medial to the sternocleidomastoid muscle at about the level of the cricoid cartilage. Avoid pressing at the level of the thyroid cartilage, since this is the location of the carotid sinus, and pressure there may result in the patient passing out. Also, do not palpate both carotids at the same time for the same reason. Now that you know where all the arteries are located, what specifically are we assessing them for? Two things. The first is the pulse's regularity, which you only need to assess once. The second is each pulse's strength. If the pulse is irregular, try to determine if it's regularly irregular, meaning there's a fixed pattern to the pulse. There are specific arrhythmias that display this specific pattern. For example, type 1 second-degree AV block, as well as something called bigeminy and trigeminy. It's okay if you're not yet familiar with those rhythms from ECG interpretation. Alternatively, the pulse may be irregularly irregular, meaning that there is no pattern, that it feels random. That's what's seen with atrial fibrillation and atrial flutter with variable block. There's a third abnormal pattern, though, that can be easily mistaken for irregularly irregular, which is regular with occasional early or missed beats. This is what's seen with sinus rhythm plus intermittent premature atrial or ventricular contractions. The reasons that some pulse beats are missing rather than all of them occurring early is because sometimes the premature beats are so early that diastolic filling has not yet occurred, and so there is minimal forward blood flow that's generated by that particular ventricular contraction. Regarding the pulse strength, along the way during your training, you'll likely be taught a numerical scale that assigns the strength of a pulse a number from 0 to 4 plus. However, there is not sufficient consensus as to what these numbers actually mean. Therefore, to reduce ambiguity and minimize miscommunication, I recommend using a single-word descriptor instead of a number. For example, describing each pulse as either absent, diminished, normal, or bounding, meaning greater than normal. On occasion, a clinician may also use the term non-palpable but Dopplerable, meaning that even though they could not feel the pulse when they used a Doppler ultrasound at the bedside, they were able to demonstrate that the vessel still has blood moving through it. A diminished pulse, and in particular an absent one, should prompt the examiner to assess the relative temperature of the extremities to see if the one without a pulse is cooler than the other side. It should also prompt the examiner to assess the next most proximal pulse in that extremity, So for example, if the radial pulse is not palpable, you would next attempt to palpate the brachial pulse on that side. On the other hand, if the radial pulse is normal or bounding, it's unnecessary to palpate the ipsilateral brachial. Etiologies of absent or diminished pulses can be separated into focal versus generalized. A focal decrease, particularly in the legs, suggests atherosclerosis. Rarer causes include an embolus, an arterial dissection in which the layers of the wall of a large muscular artery start to peel apart from one another, or vasculitis, which is autoimmune-mediated inflammation of the blood vessels. A generalized decrease in all pulses can be seen with low cardiac output, either from heart failure or hypovolemic shock, as well as with aortic stenosis. Bounding pulses are always generalized and suggest either aortic regurgitation or a hyperagenergic state such as sepsis, drug intoxication or withdrawal, and hyperthyroidism. As a general rule, if a patient's pulses are all symmetric, the subjectively perceived strength of them is proportional to the objectively measured pulse pressure, which is the difference between the systolic and the diastolic blood pressures. Now let's talk evidence. In the diagnosis of peripheral vascular disease of the legs, an asymmetrically cool leg, or an absence of both dorsalis pedis and posterior tibial pulses, substantially increase the probability of PVD, while the lack of these findings have a modest influence on ruling it out. At the same time as pulse assessment in the legs, you can also assess for peripheral edema or swelling. While edema can be generalized to the whole body, affecting all four limbs and even the torso, in that case the etiology is almost always low serum albumin and is not directly related to the cardiovascular system. Edema of the legs is primarily assessed by holding firm pressure to either the feet or shins, and seeing if the pressure of your finger pushes subcutaneous fluid out of the way and allows your finger to sink down into the patient's soft tissue. If a patient has edema, you should characterize it based on whether it's unilateral or bilateral, and if bilateral, whether it's symmetric. Describe how far up the leg it extends, and also describe it as either pitting or non-pitting, in which pitting edema is that in which an indentation transiently remains in the patient's skin even after you remove pressure from your finger. As with the pulses, there is a 4-point numerical scale that is used to grade the severity of edema. But also, as with the pulses, and even more so, there's actually no consensus on what the scale actually means. Does it refer to how far the edema pits in, how far up the leg it extends, or how long it takes for the pitting to resolve after the pressure is released? I've heard all of these over the years, and yet virtually no formal physical exam reference mentions any of them. So despite its near ubiquitous use in practice, I actually recommend avoiding use of the 4-point edema scale, and instead you should describe edema with general words like mild, moderate, and severe, which, are equally vague, but don't falsely imply agreement on definitions, which the scale does. Or alternatively, describe edema very specifically if it's a central feature of the patient's presentation. Etiologies of pitting edema are many. Just the relatively common ones include heart failure, cirrhosis, renal failure, malnutrition, deep vein thrombosis, cellulitis, chronic venous stasis, pregnancy, and a medication side effect. Because of the high number and the diversity of the different causes of pitting edema, its presence is usually of minimal diagnostic utility, and identifying it is more helpful to understand the manifestations of a disease diagnosed via other means. Using the presence of pitting edema as the primary argument that a patient has intravascular volume overload, for example, is a very common mistake. On the other hand, non-pitting edema is much less common and suggests lymphedema, which is a general term for edema that's caused by blockage of the limb's lymphatic drainage due to tumor, radiation, surgery, or infection, including recurrent episodes of cellulitis. There's also a condition called lipedema, which resembles lymphedema, But instead of an accumulation of fluid, it's actually an accumulation of adipose tissue in the legs. Lipedema can be distinguished from true edema because it spares the feet. The next maneuver I'll be discussing is assessment of the jugular venous pressure, or JVP. While interpreting JVP isn't as complex as interpreting cardiac auscultation, it seems to elicit a disproportionate share of frustration among trainees. In short, the JVP is a surrogate for the central venous pressure, or CVP, in the right atrium. Abnormalities of the JVP, either the overall pressure or abnormal patterns in the pressure that's seen across the cardiovascular and respiratory cycles, provide helpful information that's relevant to almost any cardiac condition. Because it's so important and because it's so confusing, I'll spend a little extra time here with the explanation of how this physical exam finding works, as well as its limitations. Since the jugular vein is directly connected to the right atrium via the superior vena cava, and the jugular vein is a highly compliant vessel, meaning that it readily dilates when filled with blood, but collapses when it's empty, we can estimate the CVP by examining how high the jugular vein's distension extends. In other words, we use the internal jugular vein as a blood-filled manometer. For example, suppose a patient is fully upright at 90 degrees, and the jugular venous pressure extends to this level. We can say that the central venous pressure is proportional to the vertical distance between that level and the level of the right atrium. And to simplify units, we use units of centimeters of water, using the fact that the density of blood and water are approximately the same. But how do we know where the right atrium is? Clinicians make an assumption based on an old observation that the right atrium tends to sit approximately 5 centimeters closer to the ground than the palpable sternal angle. So one can therefore determine the central venous pressure in units of centimeters of water as the sum of the height of the JVP above the sternal angle and 5 centimeters. In those patients who are unable to sit fully upright, the method stays the same. It doesn't matter what the angle is that the patient is at. All that matters is the vertical distance to which the jugular vein's distension extends, though this requires the assumption that the right atrium will still be 5 centimeters closer to the ground than the sternal angle, irrespective of what angle the patient is at. However, in practice, there are limitations to precisely measuring CVP with this technique. For example, one needs to be able to distinguish venous from arterial pulsations, and in patients of larger body habitus, the jugular vein may simply not be visible at all. There are also physiologic limitations. Measuring hydrostatic pressure, which is what we're doing, by definition requires the fluid to be stationary, which of course is not true of the blood in the jugular vein. As we can see, the JVP oscillates, with one period synchronized with the cardiac cycle and another synchronized with the respiratory cycle. In the cath lab, where there's a catheter that's directly transducing the pressure in the right atrium, the CVP is measured at end expiration. But in 20 years as a physician, I have yet to see a clinician at the bedside deliberately time their JVP measurement to the respiratory cycle. Even the sacrosanct 5 centimeters that's added to the JVP is an oversimplification. The assumption is that the right atrium is always 5 centimeters below the sternal angle, irrespective of inclination of the patient's torso and irrespective of the size of the patient, is just not true. The original descriptions of this method in a 1946 paper is illuminating. The authors openly adopted the 5 centimeter number for simplicity, and they acknowledged the uncertainties and potential sources of error which many modern physical exam references seem to have forgotten. So conceptually, this is a valid technique to estimate the CVP as long as one realizes there is a significant range of error. All these reasons are why I think attempts by old school exam gurus to use a ruler and straight edge to precisely measure the JVP to the nearest centimeter are misguided, and I wish we would stop teaching students to do this. Instead, here's a practical approach to the JVP. Unless you have a strong suspicion that the patient's JVP will be unusually high or unusually low, I recommend starting with the patient at either 30 or 45 degrees. Their head and neck should be relaxed and without a pillow. Conventionally, the right IJ is used to estimate the JVP, because the waveforms are easier to see as compared to the left, and it's examined from the patient's right side. There is a difference of opinion on whether the head should be turned or in a neutral position. Turning the head away from the side being examined is far more common, but a plausible argument suggests that this stretches the fascia and muscles across the veins, obscuring them more. I tend to split the difference between these opinions and have the patient very modestly turn their head to the left. A tight, directed light shown tangentially across the neck will cast shadows, making the waveforms much easier to see. If the room is unusually bright, you might even consider dimming it slightly for this part of the exam by drawing the blinds or turning off the overhead light. The internal jugular vein lies deep to the sternocleidomastoid muscle, and unlike the external jugular vein, cannot be directly seen. However, the pulsations from the vein are transmitted through the muscle to the overlying skin. The JVP is then typically measured at the highest point of oscillation through the respiratory and cardiac cycles. If you cannot see the pulsations, it may be because the JVP is higher or lower than you anticipated, in which case you may need to raise or lower the patient to a different angle. In short, the best angle at which to examine the JVP is the one in which the JVP is easiest to see. So that happens to be 30 to 45 degrees in patients with normal intracardiac pressures. I'd like to come back to one of the aforementioned limitations of JVP measurement: how to differentiate the jugular and carotid pulsations, which can be a real challenge with some patients' necks. If you're having difficulty with this, which is common, consider the following characteristics. Venous waveforms in healthy individuals have 2 undulations per cardiac cycle, whereas the carotid waveform has just 1. With venous waveforms, there's typically a slower movement out and then a more rapid movement in, whereas with a carotid waveform, it's typically more rapid out and gradual back in. Venous waveforms are usually not palpable, whereas carotids are. Venous waveforms usually fall during inspiration, whereas there is no effect on the carotids. And the external application of pressure to the abdomen causes venous waveforms to transiently rise, whereas the carotids are once again unaffected. In some patients, pulsations within the internal jugular vein are not visible at all, but the external jugular vein, which is superficial to the sternocleidomastoid, is visible. In most cases, using the external jugular vein to estimate CVP is fine, though the specific waveforms may be less prominent. A normal JVP is 8 centimeters of water or less, which is roughly equivalent to being able to just barely see it above the clavicle in a patient at 45 to 60 degrees. As implied earlier, it's my opinion that measuring JVP to a specific value is neither precise nor accurate, and it is thus a waste of time. Instead, I qualitatively characterize JVP as being normal, elevated, or in some uncommon cases, extremely elevated. There are some instructors who teach that an unusually low JVP is indicative of hypovolemia, but differentiating between normal and low JVP is difficult. The cutoff between the two appears arbitrary, and the primary literature makes virtually no mention of this finding. So I don't think low JVP is a diagnostically helpful finding to look for. Likewise, I would avoid the term flat JVP, which is ambiguous as to whether one is implying it's normal or is implying that it's much lower than normal, or in some cases the examiner may simply not have seen the JVP at all and is just assuming that's because its value is so low, which is an assumption that can easily be incorrect. Among patients suspected of elevated CVP, the JVP has consistently been found to be a good surrogate for central venous pressure as directly measured by catheter, though if you do attempt to measure a specific value for the JVP, it may systematically underestimate the pressure by a few centimeters of water. And if comparing the observed JVP to CVP as measured via a central line or something in the cath lab, remember that the CVP is usually measured and reported in units of millimeters of mercury, not centimeters of water. So you need to convert between the two. The causes of an elevated JVP are many, but most notably, all forms of heart failure, pulmonary hypertension, a large pulmonary embolism, and cardiac tamponade. An important point of which most non-critical care docs are unaware, there's a difference between saying that the JVP is a good surrogate for CVP and that the JVP is a good surrogate for determining fluid or diuretic responsiveness. A discussion of this distinction is outside the scope of this video, but in extreme brief, the JVP is more helpful for diagnosis than it is for guiding management. There's also a relevant eponymous finding called Kussmaul's sign, which is a paradoxical increase in the JVP during inspiration. This finding is classically described in constrictive pericarditis, but it can be observed in any cause of severe right heart failure. In addition to determining whether or not the patient's JVP is elevated, you also want to observe the specific waveforms. As mentioned earlier, the normal venous waveform has 2 undulations per cardiac cycle. The first outward movement occurs immediately before S1. This is known as the A wave, which is caused by atrial contraction. It's followed by the X descent. Then the V wave occurs around S2, followed by the Y descent. What are some abnormalities that can be seen in the waveforms? Canon A waves, which are the intermittent occurrence of a very prominent outward wave caused by the atria contracting against an already contracted ventricle, is seen in AV dissociation. In patients with severe tricuspid regurgitation, they have a giant outward wave that occurs during systole that makes the A and V waves seem connected, and absent A waves suggest a lack of atrial contraction, as seen in either atrial fibrillation or sinus arrest with a junctional or ventricular escape rhythm. A number of other waveform abnormalities are described, but they're difficult to identify without a printed tracing of the directly transduced pressure from the cath lab. Next, let's discuss listening for carotid bruits. A bruit is the name given to the whooshing sound that's generated by turbulent blood flow through a vessel. Bruits are most classically associated with atherosclerotic narrowing of an artery, though it's been reported that 1% of normal adults have them. Carotid bruits are always louder in systole. If you hear what sounds like a bruit in the neck, but it's louder in diastole, it's likely turbulent flow through an internal jugular or brachiocephalic vein known as a venous hum, which is a benign phenomenon occasionally observed in healthy individuals. To listen for a carotid bruit, place your stethoscope in a region under the angle of the jaw, anterior to the sternocleidomastoid muscle, and superior to the level of the thyroid cartilage. Notably, this is a little bit above the exact point where the carotid pulse is best palpated. Here's what a bruit would sound like. So what's the evidence for carotid auscultation? A bruit substantially increases the likelihood of a clinically significant carotid stenosis, and its absence modestly decreases the likelihood. Notably, other arteries in the body can also get bruits. For example, I discussed renal artery bruits in the core abdominal exam video. In addition to this, if any extremity is noted to have a diminished pulse, that artery should also be auscultated, since the presence of a bruit will further increase the probability of peripheral vascular disease in that limb. The final maneuver to discuss within the core cardiovascular exam is auscultation of the heart. While it's a very simple maneuver to perform, the interpretation of observed abnormalities are the most complicated aspect of the entire head-to-toe physical exam, with the debatable exception of some cognitive tests. Auscultation is classically performed with the patient between 30 and 45 degrees, though it's also fine to be done with the patient supine. Some references recommend listening to the patient in 3 locations, upright, supine, and left lateral decubitus, though I've never seen that done in actual practice. There are 4 to 5 classic locations to listen to the heart. The first 4 roughly correspond to being directly above the 4 valves. Thus, these are often referred to as the aortic, pulmonic, tricuspid, and mitral areas. However, I strongly recommend not referring to them as such, since the surface location over which a particular sound is best heard does not always sit above the valve responsible for making that sound. So instead, refer to the location by surface landmarks. The second right intercostal space, just lateral to the sternum. The second left intercostal space, also just lateral to the sternum. the fourth left intercostal space, also just lateral to the sternum, and the fifth intercostal space in the mid-clavicular line, which actually sits more over the apex of the heart than over the mitral valve anyway. The optional fifth location for auscultation is located in the left third intercostal space and is known by the eponym of Erb's point. Whether auscultation at this fifth location is necessary is a matter of opinion and personal preference. I tend to not listen there unless I'm trying to better understand an abnormality I've already heard in either of the adjacent intercostal spaces. For a patient without breasts, this exam can be performed with the front of the gown lowered to the waist. However, for a patient with breasts, we want to expose only what's necessary. Thus, for auscultation at the upper two spots, ask the patient to lower the gown to the upper breast. And then for auscultation at the lower two spots, ask the patient to raise the top of their gown back to the shoulders and raise the bottom of the gown to just under the breasts. You may also need to ask the patient to hold their left breast up and out of the way to make it easier to auscultate at the cardiac apex. Do not move the patient's breast yourself, and do not listen to the apex through the breast. Some practical guidance on auscultation and gowning and draping. First, while generally you want to expose whatever part of the body you are examining, depending on what the patient is wearing and their comfort level, you may choose to reach under the gown to auscultate in the proper location. Depending on the context, this may be okay to do, provided that you let the patient know what you'll be doing immediately beforehand. Second, if instead of a gown, the patient is wearing an article of clothing that simply isn't conducive to being raised and lowered in the same manner, and if changing into a gown is not practical, as long as the material is thin, it is not a catastrophe to listen through the clothing. Given that the sound is already traveling through several centimeters of muscle and soft tissue, an extra 1 to 2 millimeters of cotton doesn't make a huge difference. Again, it's definitely not preferable to auscultate through clothing, but it is better to do so than to not auscultate at all. Conventional teaching is that the wider and shallower diaphragm of the stethoscope head should be used for this because it better transmits higher pitched sounds, which most cardiac sounds and murmurs are. And then the deeper and coverless bell of the stethoscope is additionally used at the cardiac apex to listen for 3 specific low-pitched sounds that can occur at that location. However, after spending years using many different models of stethoscope, I found that the difference in sound between the diaphragm and the bell of a conventional acoustic stethoscope to be so small as to not make a significant difference. However, for those with access to a digital stethoscope that can apply a digital filter to selectively amplify some frequencies more than others, that does make a big difference. When listening to the heart sounds, particularly for trainees, it may be best to focus on just one particular aspect of what you're hearing at a time. So for example, first, just try to figure out the location of systole versus diastole. For patients with a normal heart rate, this can be done by remembering that systole is shorter than diastole. However, as the heart rate increases, diastole shortens more than systole. Thus, once the heart rate exceeds around 120 beats per minute or so, systole and diastole may be close enough in duration that it can be very, very difficult, if not impossible, to determine which is which just from sound alone, in which case simultaneously feeling for the patient's pulse may be helpful. Also, don't be shy about taking your time with auscultation. It's been my observation that the most common reason an examiner misses a murmur or extra heart sound is because they rushed listening for it. In a normal patient, there should be 2 relatively sharp heart sounds, called S1 and S2 for the first and second heart sound. S1 comes at the transition from diastole to systole and is generated by the simultaneous closing of the mitral and tricuspid valves. S2 comes at the transition from systole to diastole and is generated by the near simultaneous closing of the aortic and pulmonic valves. As a general rule, S1 is best heard at one of the lower two auscultation positions, while S2 is best heard at the upper two auscultation positions. But both should be easily heard in all locations, and together the S1 and S2 comprise the lub-dub of the heart. While S1 is normally a single sound throughout the respiratory cycle, S2 normally displays a phenomenon called physiologic splitting, in which it is a single sound during expiration and becomes a very subtle double sound during inspiration. This is due to the aortic valve closing slightly earlier during inspiration and the pulmonic valve closing slightly later. When the two components of S2 can be distinguished from one another, the aortic component is known as A2 and the pulmonic component is P2. To determine that the degree of split is normal and not excessive, it requires a lot of practice, but in short, a normal physiologic split S2 is just barely perceptible by most examiners. Regarding possible abnormalities that can be heard, it is an incredibly complex topic that is a focus of an entirely separate video of its own, but here's a summary of how these abnormal sounds can be characterized. There can be abnormalities of normal sounds, such as an abnormally loud or soft S1, or a variably loud S1, a loud P2 suggesting pulmonary hypertension, mechanical sounding S1 or S2 caused by a mechanical valve replacement, or a variety of abnormal S2 splitting. There can be abnormal sounds that should not be there at all. The classic examples in this category are the so-called third and fourth heart sounds, better known as S3, which occurs in early diastole, and S4, which occurs in late diastole and corresponds to the atrial kick. S3 and S4 are distinct sounds in that they are both relatively low-pitched compared to S1 and S2. Together, S3 and S4 are also known as gallops. Other less common abnormal sounds include an aortic ejection click in very early systole, the click of a mitral valve prolapse in mid-systole, and the so-called opening snap of mitral stenosis in early diastole. Then, distinct from heart sounds are heart murmurs. Heart murmurs are like bruits, longer duration acoustical phenomena caused by turbulent blood flow. They are classically subdivided based on timing, whether they occur during systole, such as that from aortic stenosis, mitral regurgitation, or in pediatrics, aventricular septal defect, or occur during diastole, such as aortic regurgitation and mitral stenosis. Other valvular diseases can also cause murmurs, but these are collectively uncommon to hear. If you do hear a murmur, in addition to its timing, there are other characteristics which you should describe. The location where it's best heard, the intensity, which is typically graded on a 1 to 6 scale. In the 21st century, it has become very rare to hear a murmur louder than a 3 out of 6 on that scale. Describe the shape of the murmur, meaning how does it change over its duration, which provides a clue to its cause. For example, here's a classic systolic crescendo-decrescendo murmur of aortic stenosis. And here is the classic holosystolic or uniform murmur of mitral regurgitation. And the classic decrescendo diastolic murmur of aortic regurgitation. Describe if the murmur radiates to anywhere, meaning is there a place other than directly over the heart where the murmur is heard? Aortic stenosis murmurs can radiate to the carotid arteries, where they might sound like a carotid bruit. Mitral regurgitation murmurs classically radiate towards the left axilla. In short, murmurs tend to radiate in the direction that the turbulent blood is flowing. Some clinicians will also describe the pitch of the murmur and the subjective character of the murmur, such as harsh or musical or blowing. This becomes a bit more advanced, but finally, murmurs can also be characterized based on how their intensity or timing change with physical maneuvers that the patient does. For example, what effect does deep inspiration, isometric hand grip, a Valsalva maneuver, or sudden standing have on the murmur, all of which can provide information about the underlying pathology. There are two specific murmur terms that are frequently misused. The first is a flow murmur. This is a murmur caused by blood moving through a physically normal valve in which the turbulence is caused by either low viscosity of blood from anemia or a high velocity of blood in states of catecholamine excess, such as sepsis. The second misused term is an ejection murmur, which is a systolic crescendo-decrescendo murmur heard at the upper sternal borders caused by blood moving forward through the aortic or less commonly pulmonic valve. I find this latter term to be vague. Some clinicians use it to describe any systolic crescendo-decrescendo murmur, while others specifically use it for early murmurs, that is, systolic murmurs that do not extend all the way to S2. For some clinicians, the term implies an etiology other than aortic stenosis, while others routinely refer to the murmur from aortic stenosis as an ejection murmur. So, in short, flow murmur is fine if used correctly, but I would avoid the term ejection murmur since you don't know if the listener or reader has the same understanding of the term as you do. As mentioned, if you want a more in-depth discussion of cardiac auscultation, there is a separate video that does an even deeper dive on this. When it comes to the evidence behind cardiac auscultation, I'm only going to focus on a couple of key findings to remember, but there are many more in the literature. An absent or soft S2 in a patient who concurrently has a systolic crescendo-decrescendo murmur increases the likelihood of aortic stenosis. Although it's frequently taught and is my personal experience that a loud S2 is suggestive of pulmonary hypertension, this has not yet been shown in the literature. The presence or absence of an S3 is helpful at identifying or ruling out a reduced ejection fraction. However, neither the presence nor absence of an S4 is helpful in determining whether a patient has elevated left-sided filling pressure. This surprises a lot of people because the S4 is frequently taught to be a sign of diastolic dysfunction, but in fact, it's more or less a useless finding, whose primary significance is that it can be mistaken for something else or vice versa. Whether or not the examiner hears a characteristic murmur of aortic stenosis, aortic regurgitation, or mitral stenosis, all will have significant impact on the presence or absence of those valvular diseases. And here the meaning of characteristic, quote unquote, refers to a combination of classic timing, shape, and location. I'll end with a discussion of the documentation of the cardiovascular exam. As with the exam as a whole, there is more nuance here than with the documentation of other exam components. Inspection is not typically included in documenting the CV exam, and instead, by convention in the US, documentation of a normal exam starts with RRR for regular rate and rhythm. I'm not a huge fan of this terminology as I'm not sure what a regular rate even means. If it just means a normal rate, well, that would already have been documented under the vitals. I think just regular rhythm is fine, though you may hear some old school physicians object to this as well, saying that a regular rhythm can only be determined with an ECG and that regular pulse is the more accurate description, but this seems excessively pedantic. It's conventional to follow this with normal S1 and S2, though be careful to not misapply this phrasing. For example, saying that S2 is normal implies the existence of a physiologically split S2 during inspiration. If there is no S2 split, then I would instead document normal S1, absent S2 split. Next, clinicians will frequently write no M, R, or G for no murmurs, rubs, or gallops. This phrasing also has seemed strange to me, since pericardial rubs are rare, and we don't make a habit of routinely mentioning the absence of any of the other hundreds of equally rare findings we might conceivably encounter on the exam. I think no murmurs or gallops is fine, but no murmurs, rubs, or gallops is much more common. If a patient has a murmur, be sure to describe it as already reviewed: its intensity, timing, shape, location, and radiation, most often in that order. And remember that intensity is actually the least important murmur characteristic, despite it being the one most likely for the clinician to include. Some clinicians document the carotid auscultation and JVP assessment in a section for the neck, where it's grouped with the assessment of the thyroid gland. Now, I understand the logic with that, and it's not unreasonable. I personally prefer to mention these in the CV section. Carotid bruits are either present or absent, and if present, be sure to include which side. For JVP, as previously discussed, many exam experts recommend providing a specific number in units of centimeters of water. This is fine, I guess. Some clinicians, typically cardiologists, are really attached to it, and on the words, you have to pick your battles. But also, as discussed, bedside estimates of JVP have a lot of limitations. So I think it's not only okay, but maybe even preferable to simply state JVP normal, elevated, or extremely elevated, or alternatively mention its elevation in reference to a landmark, such as elevated to the angle of the jaw with the patient fully upright. If the JVP is not visible at the angles at which you examine the patient, state that and mention the angle. Do not simply say no JVP or JVP flat. Then pulses. As I mentioned earlier, I recommend avoiding a numerical scale here and instead labeling pulses as absent, diminished, normal, or bounding. And last, discuss edema, also avoiding the extremely vague numerical edema scale. If the edema is a small part of the overall clinical picture, it's okay to qualitatively describe it as mild, moderate, or severe with reference to how proximally the edema extends. And instead, if the edema is a significant part of the overall clinical picture, such as the patient's chief complaint, consider objectively measuring limb circumference at a specific reproducible level, such as the mid-shin. That concludes this in-depth discussion of the core cardiovascular exam. I'd like to thank Radhika for her assistance today, and also be sure to check out the core cardiovascular exam without commentary to see the flow of maneuvers in practice, as well as another video that covers a few specialized maneuvers.